Please go ahead.
Good evening, everybody. Today we'll be discussing a case of multifocal choroiditis. So, a 27-year-old male presented to us with a complaint of redness in both eyes since 15 days, watering in both eyes since 15 days, and diminution of vision, which was painless and gradually progressive since 15 days. The vision was 6 parts in the right eye and 6 part in the left eye. There was CCC, circumciliary congestion, in both the eyes. There were mid-sized fresh capies in the right eye and fine capies in the left eye. AC had 2+ cells in the right eye with 1+ flare, and it had 3+ cells in the left eye with 1+ flare. Left eye had pigment on anterior lens surface, and both eyes had 2+ cells in the vitreous. Fundus findings. Right eye had disc edema, venous tortuosity, multiple subretinal grayish yellow patches over the posterior pole, and there were multiple retinal hemorrhages with white center. In the left eye, there was disc hyperemia, venous tortuosity, and subretinal grayish yellow patches more in the mid periphery. As we can see over here, right eye had disc edema, it has venous tortuosity, and multiple grayish yellowish lesion, subretinal lesion at the posterior pole and in the mid periphery. Whereas in the left eye, these lesions were more in the mid periphery than on the posterior pole. And even there was a mild disc hyperemia in the left eye, whereas there was disc edema in the right eye. We did OCT, and here what we got in the right eye, if I just zoom it for the convenience of. So there was a hyper-reflective RP, it has granularity, and there is focal EZ, ISOS loss, and the ELM above it looks normal, it looks intact. So there's a focal ISOS loss, there is granularity and hyper-reflective RP. And at some places, you could see this nodularity in the RP. Whereas in the left eye, as I have already told, that they were less on the posterior pole and more in the mid periphery. So we couldn't get it on the OCT scan.
Also, vitreal hyperreflective dots were there in the OCT.
Yes, sir. Yes, sir.
In both the eyes.
Both the eyes, yes, sir.
Right more than left.
Right more than left, yes, sir. On doing fundus autofluorescence, we could here appreciate that there are few patches which are with hypo autofluorescent margin and few patches with hyper autofluorescence. In the right eye as well as in the left eye, there are few hyper autofluorescent and few which are hypo autofluorescent. Then on evaluating more, the patient gave us a history of positive VDRL and TPHA in 2019. Patient had tongue chancre in 2019. So a diagnosis of syphilitic multifocal choroiditis was made at this point of time, and patient was started on topical steroids with antibiotic and cycloplegics and was advised a battery of tests. In the test, hemoglobin came to be normal, ESR was 11, ACE was 22, HbS, Ag, HCV, and HIV 1 to all were non-reactive. Peripheral blood smear showed a microcytic hypochromic anemia. Chest X-ray showed normal skygram. TPHA was reactive and VDRL was reactive with a titer of 1:1. So the patient came the next day for FFA and ICGA, and here we could see in the early phase FA, we could see some hypoautofluorescent patches over here, whereas in the ICGA we could see hypocynoscent patches, which are more pronounced than these patches, because the ICGA, it shows the disease more elaborately. Here we could see so many hypocynoscent spots, whereas in the FFA we couldn't appreciate those many hypo or hyper autofluorescent spots. In the right eye as well as in the left eye, there are more hypocynoscent patches. In the late phase, there was diffuse disc staining, as we can see, the hot disc, and these the patches which were hypoautofluorescent, now they are showing some hypoautofluorescent margins, whereas the lesions continue to be hypocynoscent in the right and in the left eye. Patient was sent to a physician and physician advised IM injection benzathine penicillin 2.4 million units weekly for 3 weeks. And on subsequent visits, oral corticosteroid was started along with topical steroid and cycloplegics. This was the follow-up OCT. Here we can, I just put this OCT just to show that here we can see a amount of SRF in the right eye. Just nasal, just temporal to the disc and nasal to the fovea. We could see some SRF here. This SRF could be because of the neuroretinitis, as we have discussed in the class earlier, where I was discussing the OCT signs in posterior uveitis. The neuroretinitis usually have a hot disc on fluorescein angiography. It usually has IRF and SRF near the disc. And this SRF usually tracks down towards the fovea. Now we'll be discussing a journal. And the journal goes like acute syphilitic posterior placoid chorioretinitis, when the great mimicker cannot pretend anymore. New insight of an old acquaintance. This article was published in JOI in 2022 and it was given by Neri et al. Introduction. The surge report in 1990 recorded 20.3 cases per 1 lakh population. Treponema pallidum, which is a syphilis bacterium, has a thin and elongated structure. It slowly grows and may chronically infect the host. Consequently, the primary lesions are generated right at the site of inoculation, initiating the phases of the disease. The bacterium spreads via the bloodstream towards the CNS, where it triggers the local immune system, generating a consequent neurodegeneration. Syphilis has a broad spectrum of clinical presentation during its early stage. Once a patient has seroreactivity without other evidence of primary, secondary, or tertiary disease, this phase takes the name of latent syphilis. Now we'll come on to the ocular manifestation. Eye involvement is more likely to happen during secondary and tertiary syphilis, even though this may occur at any time. Anterior segment seems to be less likely to be involved. The posterior pole offers a broad spectrum of possible clinical patterns. Treponema pallidum is capable to affect all the retinal layers. Posterior uveitis is the most typical clinical presentation in syphilis. Retinochoroiditis is the commonest posterior pole manifestations, and it presents as a macular placoid lesion. The discrimination between acute and chronic syphilitic posterior uveitis is crucial for the decision making and the long-term outcome. In the acute phase, the uveitis is florid. It progresses rapidly, often associated with meningeal involvement. Other possible pattern of presentation can be neuroretinitis, as we could see in our case, chorioretinitis, retinochoroiditis, retinal necrosis, vitreous involvement might be significant, papilledema, multifocal choroiditis, as the case I've presented in this presentation, low-grade retinal vasculitis, pre-retinal precipitates, as you can see over here. These are pre-retinal precipitates. These are basically aggregates of T cells, and they are usually above the retinitis lesion. Punctuate retinitis can be present, occlusive arteriolitis. Now we'll come to the presentation of acute syphilitic posterior placoid chorioretinitis. The placoid form is characterized by a ground glass pattern. It is large, roundish, yellowish placoid lesion occurring at the level of RP at the macular or paramacular area. As you can appreciate in this figure, this is the lesion, which is large, roundish, yellowish placoid lesion. It's subretinal. On fundus fluorescence angiography, progressive hyperfluorescence within the involved area can be seen. A scattered focal hypofluorescence can be seen. And leopard spotting-like appearance can also be seen. As you can see here, is hyperautofluorescent. That lesion which was shown earlier in fundus photograph, it shows a hyperautofluorescent pattern in FFA. On ICGA, a hyperfluorescent area is seen. It may be due to choriocapillaries hypoperfusion or blockage of the choroidal fluorescence by the overlying affected RP. As you can see in this, the lesion which is hyperautofluorescent is hypocynescent on ICGA. On fundus autofluorescence, it is usually hyperautofluorescence. As you can see here, placoid lesion are hyperautofluorescent. Tiny hyperautofluorescent dots representing RP photoreceptor complex material overlying the RP due to an impaired metabolism of RP itself. As you can see here, there are few dots, hyperfluorescent dots. On OCT, we can see an intact ELM, disrupted EZ, thickened and granular hyperreflective RP. Subfoveal RP choriocapillaries complex appear thickened and hyperreflective. Acute loss of choroidal vascular structure and hyperreflective spots in the choroid. As we can see in the OCT, there is intact ELM, there's ISOS loss, and there is hyperreflective granular RP, which has nodular elevations. One-month antibiotic therapy lead to a complete restoration of EZ band with normalization of RP at OCT. As well, it leads to the resolution of hyperreflective spots at the choroidal level. Syphilis characteristically presents episodes of active disease alternating with periods of latency.
Baby.
Choroidal hyperreflective spots represent inflammatory foci in the choroid vasculature. Antibodies might react with treponemes in the choroid and lead to RP choroidal involvement. Such antibodies might lead to regional choroidal occlusive events. These occlusive events lead to altered RP metabolism with disorganization of RP structure. And hyperacute disruption of outer blood ocular barrier might also produce variable amounts of SRF. Now on the investigation algorithm, basically there are two schools of thoughts. One school of thought says that we should do the non-treponemal antibody test first and then go to treponemal antibody test. And the other school of thought says that treponemal antibody test should be done first, then we should go to non-treponemal antibody test. So I have just tried to simplify this. The usual algorithm is we go with the non-treponemal antibody test first. So we do the VDRL or RPR. If it's come positive, that means that it is syphilis of any stage or it's a false positive test. If it comes negative, then it can be a primary or latent syphilis or there is no syphilis. If it comes positive, we go to the treponemal antibody test. If that also comes positive, that means it's syphilis. If it comes negative, then it's a false positive test. And even if it comes, VDRL comes negative and we go with treponemal antibody test, if it comes positive, then it's a primary or latent syphilis. And if both comes negative, then there's no syphilis. Basically, the other school of thought says that we should go with treponemal antibody test first. If it comes positive, we should move to VDRL or RPR. Now, if the VDRL comes negative, we should again do a treponemal antibody test, but with some other method. Like if we went with EIA at the earlier stage, we should go with TPHA. If that also comes positive and the patient had already taken a treatment, so no further treatment is required. If the test comes negative, then no treatment is required. As in the first test is not corroborated with second test, the positive report. So we'll consider it as no syphilis. I know it's confusing. I've tried to explain it, but if it's any doubt anybody have, I can explain it again.
So yeah, this is important, Vaibhav. So my question to you is that, so it means that the TPHA is a specific test for syphilis.
Yes, sir.
And the RPR or VDRL is basically, it's a non-specific test, right? It's not very specific.
Yes, sir. But then, sir, it has its importance in that the titer of VDRL, it tells us about the treatment. It tells us about how good the treatment is going. That the titer should fall below fourfold below the level, the base level.
Okay.
And then we can say the treatment is working. Otherwise, if it doesn't fall below,
okay,
then it is said that there's a treatment failure or there's a resurgence of infection.
Okay. So with treatment, will the VDRL become negative?
So the titer will fall, sir.
Okay. So which test becomes negative when the treatment is complete?
So VDRL will go negative. TPHA would stay positive, sir.
So once positive, TPHA always stays positive?
Yes, sir.
And with the VDRL, it responds to treatment, so the titers go down if the treatment is successful, right?
Yes, yes, sir. Yes, sir.
Dr. Shweta, what would you say to that?
Yes, so VDRL is used to just monitor the activity of the disease. So depending on, it will vary according to whether it's in the latent phase or whether there's a reactivation or whether there is remission. But TPHA, if it is once it is confirmed on TPHA that it's positive, it will always remain positive. So
So
it's like a all or none thing with TPHA,
right.
and VDRL is just to monitor the activity.
So I think when we are following these patients up for any recurrence or for any, like non-response, then VDRL, like Dr. Weber was saying, will be, the important test to, the serial titers will be important. Whereas TPHA is a specific test just to establish the diagnosis. Is that correct?
Yes, sir.
Yes, sir.
So I think if we're evaluating somebody for the first time and we have to really choose between VDRL or TPHA, I think TPHA is the thing to go to, like he said in the reverse algorithm.
Right.
Because that has, like, I think a lesser rate of false positive tests also than VDRL.
Right. So I think initially TPHA is more important when you have to establish the diagnosis. And
Yes,
for
sir.
serial follow-up, VDRL is, a better test.
Yes, sir.
Yes, sir.
Yes, sir. And in doubtful cases.
Right.
Like then combine the two.
Then we can combine the two. And like he said, that if we have already done one TPHA and that comes negative, then we can go on to the other kind of specific.
Other diagnosis. Yes, sir.
Yes,
Other
sir.
Go to TPPA or go to EIA or go to FTABS.
Yes. Yes,
Right.
sir. Yes, sir.
Right.
Yes,
Go
sir.
ahead. Go ahead. Thank you.
Yes, sir. Now, one interesting thing which I found in this article, that CDC suggested that selected patients should receive lumbar puncture for the diagnosis of syphilis on the basis of following criteria. First one, the central nervous system, ocular or auditory involvement raising the suspect of active tertiary syphilis. Second, the evidence of treatment failure with long-lasting quadruple VDRL or RPR increase or elevated RPR titer more than 1:32 that does not decrease to titers for 6 to 12 months in early syphilis or 12 to 24 months in latent syphilis. Now, what I think in our case, what the physician might have missed, or I don't know what, but we didn't get a lumbar puncture done. So we couldn't say that it's a neurosyphilis or it's not a neurosyphilis, because ocular can be in second or tertiary, but we need to rule out this if there is any CNS involvement in this or not, which we can only say after lumbar puncture as the CDC has suggested. So any take on this, sir?
So, so another thing is that I think these are invasive tests, so it's not very easy to, kind of convince the patient or the treating physician to, go for a lumbar puncture, although it may be important to establish CNS involvement. But
Yes,
are there any other telltale signs based on the fundus finding, which suggests that it could be, like, a case of neurosyphilis, or, I mean, is there anything else apart from this invasive testing?
So he had disc edema, and I think the only reason the physician did not opt for lumbar puncture was because the VDRL titer was 1:1. So basically, he thinks it's like a false positive at this stage, and there's no resurgence yet. And maybe what we can, I think, maybe we can repeat the VDRL titer from another lab, because I don't think it was a reliable one where he got it done. It wasn't like a very standard pathology lab.
Okay. So currently, is the patient on treatment? I mean, he was prescribed, IV penicillin, but has he been given anything?
He's received one dose of intramuscular benzathine penicillin, and he's been advised like 3 doses once a week for 3 weeks. And after the first dose, 2 days after the first dose, I initiated oral steroids. So at 60 mg because of the extensive posterior segment involvement.
So is this the recommended dose? So like we commonly hear that, the treatment of syphilitic neuroretinitis is similar to the treatment for neurosyphilis. So the treatment recommended was IV, right? IV penicillin, but he's
Yes, sir.
received muscular penicillin. So what regimen is this? I mean, and what is the recommendation of that regimen? The one that is given once a week for 3 weeks, IM?
I don't know, so what protocol that fits into, because even I thought initially he would receive like at least if not intravenous, then intramuscular benzathine penicillin for 12 to 14 days. I mean, 18 to 24 million units.
Daily,
But
daily,
sorry,
on a daily basis.
daily for
Yes.
14 days consecutive. But
But only on
he,
week. Yeah. So I don't understand
that's what
that kind of treatment.
Sir,
I
I'll just finish my presentation with the treatment part, sir.
Yeah, please go ahead.
Yes, sir. Now, as sir was discussing the treatment part. So basically, I have tried to sum up in this chart. If there are signs or symptoms of primary or secondary syphilis, or there is early latent syphilis, then a benzathine penicillin of 2.4 million units IM, a single dose is prescribed. If it's a late latent syphilis, then a benzathine penicillin 2.4 million units IM once a week for 3 weeks. 3 doses are prescribed. If the patient has sign or symptoms of tertiary syphilis, or patient is HIV positive or otherwise immunocompromised, a lumbar puncture has to be done. Sign and symptoms or CSF finding consistent with neurosyphilis? If yes, and there is no penicillin allergy, then aqueous crystalline penicillin 3 to 4 million units IV every 4 hours for 10 to 14 days is prescribed, or procaine penicillin 2.4 million units IM once daily plus 500 mg of probenecid orally 4 times daily for 10 to 14 days prescribed. In neurosyphilis, basically, the benzathine penicillin doesn't cross the blood-brain barrier and there's no bioavailability. So aqueous or procaine penicillin are prescribed. Now, like in our case, like ocular symptoms come in tertiary or secondary, but a lumbar puncture was not done. If it has been done and there were no CSF findings consistent with neurosyphilis, then benzathine penicillin 2.4 million units once a week for 3 weeks are prescribed. I don't know if he's following this one or this normogram for the treatment of our patient. That's one confusion I had.
I think since we have specified that, he has ocular involvement, and, what we are seeing is maybe, the tertiary or the late syphilis. So I
Yes,
think
sir.
likely following this negative lumbar puncture, finding protocol,
Yes,
on,
sir, this one.
yeah, rather than the late latent syphilis.
Late.
Yes. Please go ahead. Yeah.
Yes. And the negative treponemal specific test, if there's primary syphilis suspected, then we obtain quantitative non-treponemal test titers and a single dose of benzathine penicillin 2.4 million units IM is given. If it's a false positive test, the result is suspected, then we have to consider other causes. Thank you.
So just go back to this flow chart. And so what do you think, and what does Dr. Shweta think, that what should be, like you said, we can get the VDRL repeated. So what do you think that we should be doing now for this patient?
So after 3 doses, we should repeat a VDRL just to see the titers, if they are falling or not.
or if they are rising, or I don't
Or
know.
if they're rising.
Yeah.
So is there any neuroimaging that can be done short of, doing an invasive lumbar puncture? Is there any neuroimaging which can tell us about, CNS involvement?
Sir, I'll
MRI,
have to
brain
read
and
about
orbit.
that.
So, because in view of the papilledema, I mean, disc edema unilateral, we could have done, I mean, I was expecting he would have, the neurologist or the physician should have advised that, but he got an all clear somehow.
So who was the primary physician? I mean, in some institute-based one or some private practitioner?
So, Kailash, at Kailash.
Okay. So I think what we can do is that we can ask for a repeat VDRL test.
Yes, sir.
We can maybe ask him to take a second opinion.
Yes, sir.
Because if we have not conclusively ruled out neurosyphilis, then
Yes.
it's not a very good idea to kind of just fire in dark. I mean, like we should know where we are and what exactly is the stage of syphilis which we have, and whether there is any neurological involvement. So I feel that we should get this VDRL repeated, and we should also get another neuro consult.
Yes, sir.
Yes, sir.
One more thing, sir, I could not understand. Like when we saw him, there were rot spots, multiple rot spots, and that too only in the right eye. Right was obviously the more active one in terms of the lesions also. But I still got a peripheral blood smear done, and nothing came on that.
So what about the CBC? I mean, like, is
Yes,
the RBC count and all the other parameters, the counts are okay?
hemoglobin was decent, and it was normal, near normal. I think 10.
10.8, yes.
No,
And
what
there was a
about
microcytic hypochromic anemia, but rod spot only in one eye.
right? And what about the RBC parameters, like the MCV and the MCHC, and all those parameters were okay? CBC in the CBC?
Uh, the DLC was grossly okay, so I mean, I'll just look into that again. I mean, I'll have
Okay.
to check that. Yes, sir.
Okay, and what other differentials can we think of for this kind of picture? Like, can you go back to like the fundus picture? We don't have better pictures in this. It's not very clear.
Yes, I
HRA,
asked for it.
Yes. Yeah. So we can maybe whenever he comes next, these are not very clear. So is the media clear? I mean,
this
So
right,
there's a
I had
thickness.
like a lot of vitreous hairs that day.
Yes, sir.
Left, not so much.
so maybe we can repeat it when he comes
Yes,
next.
sir. Yes, sir.
Yes, sir.
So what other differentials can we think of in such a case? So in a neuroretinitis, what are all the differential diagnoses one should think of?
Lime, cat scratch.
Right. So is there any, did we take a history of, any tick bite, or, any travel to any forest area, or, did we go into that, or any kind of fever that the patient had?
There's no history of fever, but I did not specifically ask for an insect bite, although I did ask him if there were any dermat lesions that he had all over. So he did not complain of anything in particular, except for the tongue chancre that he had had 2 years ago, which he referred to as like a painless white lesion, and that was when he was actually diagnosed with this condition.
And what was the treatment that he had received for the primary chancre?
Um,
It's a
he had received single dose only at that
single
time.
dose penicillin.
Yes, sir.
And those details were available, or it was just a verbal history?
No, verbal, sir.
Verbal.
Okay. And what are the other causes of neuroretinitis? Viral.
Viral.
So you can have even things like chikungunya, which can give rise to like a neuroretinitis.
Yes, sir.
Okay.
Even dengue can give rise to neuroretinitis. But we didn't see the changes in the OCT, which are characteristic of dengue.
Yes, sir.
Mhm. No foveolitis.
No foveolitis. And at any stage, so how long is the history? How many days is the history?
15 days, sir.
15 days.
Patient
So
has been complaining.
there is no evidence of like a macular star formation as yet.
No,
No,
sir.
no,
No, sir.
no, sir. There was hardly any SRF even at that time. I mean, not much exudation. It was a lot of these RP lesions in different phases of healing and activity, like all over the posterior pole and in even in the periphery, far out also.
What does that signify when there are different phases of healing?
Multifocal choroiditis and
And does it point to any etiology? Like
Yes, it's syphilitic.
it has been shown
Yes,
that
sir. Yes, sir.
have
Yes.
various stages of healing, in the same eye, and then it is likely to be a syphilitic process.
Yes, so that was picked up on the autofluorescence.
Right.
Yes, sir. Even not so much. I don't know if he has a good montage picture, but in the on the HRA in the FFA we can see different lesions when in different directions. If we can make a mosaic out of that later.
Yes, ma'am. It was in the mid periphery and periphery, ma'am.
Yes, yes.
So do we have like a mosaic for the FFA and ICG for this patient? I mean, like on the HRA, has a mosaic been made, or
We can
No, sir.
compute one, sir.
we can try to make one, right?
Yes,
Yes,
sir. Yes, sir.
And definitely, get better fundus pictures whenever the patient next.
Yes, sir.
So any other thoughts, Dr. Das?
HIV was done.
HIV was negative, sir.
yes, sir. It was
Even in
non-reactive.
2019, he said he was tested, and even that was negative. And this time also.
So I think we should keep documenting and following up this case, and definitely get a second neuro consult, because we need to be sure that the treatment he's receiving is the correct one.
Yes, sir.
So if you just one thing which I noticed here in the angio that you've opened, that
Yes, sir.
along the infratemporal arcade, can you see these areas which are dark, and also these like very pinpoint, like hyperfluorescent thread like areas, and dots?
Yes, sir.
What is this pattern? Is this anything that we can kind of look into, whether it's anything specific?
So is it the vasculitis that's causing this perivascular hyperfluorescence?
Right. So could it be like ferning, like a ferning pattern, just the beginning of the ferning pattern, and then and if we follow this up, then it will be more like a classical ferning pattern that we have.
Yes, sir.
So I think here the mosaic picture might help us, like just putting it together, because like how it is from this place onwards towards the equator and the mid periphery would be interesting to see.
Yes, sir. I'll just ask Suvin to do that, sir, tomorrow.
Yes, and whenever we take the fundus picture next, we can put that also and try to get better pictures, and maybe you can update us regarding all the follow up and the serial VDRL report, and the neuro re-opinion, second opinion that we have, and maybe we can work up the case further.
Yes, sir. I'll do that, sir.
Dr. Shweta, any other thoughts?
No, so I think he should be back in another 5 days. So 5 days or so, 5 more days. So I think we can do all that. So and then see where it's going.
Okay. And is there any resistance, like you said, non-response? So is there any resistance to these drugs that has been reported? And what do we do in that case? I mean, do we go for some other test or some other treatment, or has there been any protocol for that, like a resistant syphilitic case?
Yes, sir. I'll just go back to the chart again.
Yes.
Yes, sir. Now, in where there are signs and symptoms of primary, secondary syphilis or early latent, If the patient is resistant or allergic to benzathine penicillin, then we can give doxy, sir, 200 mg BD for 10 to 14 days.
Doxy. Okay.
Yes, sir. And the latent phase, where we have to give a weekly dose for 3 weeks, there we can give doxy 200 mg BD for at least 21 to 28 days.
Okay. So, Dr. Shweta, if you remember, we had a couple of cases of plecoid chorioretinitis that we had,
Yes,
you
sir.
know, which the primary physician and the VDRL had not come positive. It was negative. And we had treated those patients with doxycycline, but I think our dose may not have been adequate enough. Would you remember?
200 mg, I think we gave OD. Although the duration fits, I don't remember 200 BD, sir, for any patient.
That's what. So I think when we look back, at the those cases, we tried empirically doxycycline, but I think we gave 200 OD, not 200 BD.
Yes, sir. I mean, yeah, there was that one case that had like a very typical plecoid lesion, and who didn't I think he went to PGI, but he did not come back.
Right.
Yes, sir. Yes, sir.
Okay, I think that was good. I think well documented. So I think we have food for thought, and we know how to work this case, henceforth. And also remember that syphilitic chorioretinitis is something which, and neuroretinitis is something which is there, and we should keep it in our mind as a differential whenever a patient presents with such a picture. And it's definitely now being seen fairly commonly, and so let's wait and see how this pans out in the future. So any other points anybody wants to add, or any other queries? So if not, then we can close it here. And do we know for the Friday if we have a confirmation of any class from the anterior segment side? Dr. Amrita or Dr. Tulsi, are you going to present? Do you know if you're going to present anything on Friday?
So we haven't planned on
So-
anything, but we'll find out. Sorry, Dr. Tulsi, you have something?
Yeah, I was about to say the same.
Okay. So sure. So you can whenever, as soon, because I think it would be good if you can present then, and you can maybe post it on the group.
Sure, sir, we'll do that.
Okay.
Okay.
Yeah. Thank you so much, everyone. Thank you. Thank you. So I think.
Thank you, sir.
Thank you,
Good
sir.
Thank you, sir.
night. Good night.
Good night, sir.
Good night, sir.